introductions so we know who's participating. David Romans, HSCRC.
Donna Kenzer, HSCRC.
Jerry Smith, HSCRC.
Ellen Englert, HSCRC.
Mike Robbins, Maryland Hospital Association.
Kristen Pulio, Adventist Healthcare.
Barbara Bracano, Adventist Associates. Tricia Rade, DHMH.
Ann Meck, University of Maryland School of Nursing.
John Heber, Care First.
Bob Murray, Care First.
Stu Gutterman, Commonwealth Fund.
Steve Ports, HSCRC.
And if the folks on the phone, are they muted? Or, okay. If folks on the phone want to go ahead and introduce yourself.
Mary Jo Braid Forbes Health Research.
Raymond Gray, Trivergent Health.
And we also have Michael Coran. I'm still working on getting his audio.
Okay, we have a pretty full agenda. All right. We have a pretty full agenda today, so I think we can just jump in and get started. The first topic is going to be our analysis of the impact of the Medicaid expansion, the Affordable Care Act expansion, sort of on hospital utilization and what the ongoing impact might be. So we can jump to slide 2. So the way we went about looking at this is to focus in on people who enrolled in the expansion in the first quarter of calendar year 2014, so the very first quarter of the expansion. And so that captured about a little over 200,000 people. 98,000 of those folks were folks who just transferred over from the old PAC program, which provided a more limited benefit package for Medicaid folks. In terms of hospital, it only covered ER. And then there were about 114,000 new enrollees, people who are not coming from the PAC population. We worked with CRISP and with Medicaid, and we matched up the Medicaid enrollment files for these groups against our case mix data with the goal of tracking the hospital utilization for this population of people in both calendar 13 and in calendar 14, wherever their payer was in either year. We're just looking at their total hospital utilization each year. Okay, so the kind of high-level results are on this slide 3. In calendar 13, this group of people incurred about $542 million of costs or charges at hospitals. And in calendar 14, same group of people incurred $762 million of charges at hospitals, so about 220 million growth. Now, one of our initial concerns was, since we only looked at people who were in the expansion in that first quarter, were we really capturing sort of the full year impact of the expansion? So we looked at the overall net growth in Medicaid, self-pay, and charity for all of calendar 14 versus calendar 13, all payers, everybody. And that growth for the year was about 244 million. So we've captured almost the entire growth in those populations by just looking at this quarter of people. So we think this is a pretty accurate picture of the growth that relates to the expansion. The other way we looked at it, just again, as a sort of another way to confirm whether the numbers are in the right ballpark, is equivalent case mix adjusted discharges. We pulled just from our case mix data, looked at anyone with an expected payer of Medicaid, self-pay, or charity, and compared 2013 to 2014. And we see, nearly 14,000 growth in equivalent case mix adjusted discharges. And if you price that growth at the 2013 charge levels, you come up with about 218 million. So looking at it different ways, we kind of concluded that we think we're in the right ballpark in terms of the growth and costs related to this population. So the next thing we did is look at it on a quarterly basis, see how trends changed over the course of the year. And if you look at slide 5, quarter 1, you can see there was 77 million of growth, 64% jump in utilization versus the same quarter in the prior year by this expansion cohort that we were tracking. And then that percentage falls to 51% in the second quarter, 35% in the third quarter, and down to 18% by the fourth quarter. And we also took a look on the bottom line of the chart just to see if overall charge trends at hospitals helped contribute, were different by quarter, and whether that contributed to the change. And you can see there was a little bit of bumpiness, but it certainly doesn't explain the overall drop-off from 64% in quarter 1 to 18% in quarter 4. So sort of our initial reaction to this is it looks like there was some pent-up demand. People came in, used a lot of services when they first had coverage, and then it sort of has died down a little bit after they've had coverage for a period of months. The next slide breaks it out. We just thought this was interesting into the PAC population and the non-PAC expansion folks. And the PAC folks had been in some level of managed care, although their benefit package was limited. And you see they didn't spike all that much in quarter 1, about 30% growth. And then they were more steady. They didn't drop off a whole lot by quarter 4 either. So this appears to reflect that these people already had some access to health care and were sort of high-need people and continued to use care at a pretty high level. The non-PAC group, you can see, was where we saw the enormous spike in quarter 1, going up 129% and dropping down to 16% by quarter 4. So again, this seems to support the idea there was a lot of pent-up demand. A lot of these folks didn't have coverage or were severely underinsured. Once they had coverage for extended periods, they got their services taken care of. We also looked at it by a product line. We're still tweaking our product line analysis. I didn't present all of the detailed data, but in general, where we saw the growth was surgery, just about every type of surgery you can name. Cancer treatments, radiation, chemo, infusions, cardiovascular services, and clinic services. And that was true on both the charge side and for the most part on the actual visit admission side. The next slide really just sort of recaps what we talked about. Growth slowed over 2014, pent-up demand, and just notes that these costs were covered in large part in fiscal 15 by uncompensated care that was built into the rates being higher than the actual uncompensated care that's being reported. So there was some excess funding on the uncompensated care side for hospitals that helped them to pay for this higher than expected utilization. Any questions before I get into our sort of recommendations? Sure, Barbara.
So I'm a little confused. You had calculated. Just turn your microphone on.
Oh, I'm sorry. Hello. The decrease in uncompensated care was more than expected, less than expected. I'm not sure how to read this.
We budgeted, or we set uncompensated care levels for fiscal 15, assuming about 6.14% uncompensated care. The actual, what we're seeing in the data so far for this year is more than 5.2%.
What happened, if just to refresh my memory, what happened with regard to the trends in uncompensated care from 2013 to 2014?
There was a slight uptick.
There was an uptick in uncompensated care?
I'm sorry, in 2013 there was a
2012 to 2013, there was a slight uptick. 2013 to 2014, we took it down 1%. We took the rates down 1%, and then now we're saying in 15 we took the rates down.
Because I just remember some discussion previously. Had we thought that from 2013 to 2014 the uncompensated care may have dipped more than it actually did? Was that something I remember from an earlier discussion?
Yeah, we're going to talk more about uncompensated care in the next part of this presentation. But yes, what happened in the current year is the Affordable Care Act implementation resulted in a bigger drop in uncompensated care than we had built into the hospital rate.
David, I do have three questions, if I could. First, two questions and a comment. First, during the year, the enrollment that you looked at, you took what happened for the drop in the trend for people who were enrolled in the first quarter of the year. But weren't there, additional enrollees who came on second quarter, third quarter, fourth quarter, where we could expect even, perhaps it's a lower number of people than enrolled in the first quarter, but expect a similar kind of initial ramp up and then spend down over their first full year of coverage?
So there was some continued enrollment growth. It's hard to tell from the data how much of it is people moving from various Medicaid eligibility categories when they're redetermined. So someone who might have been in the regular Medicaid program whose income has gone up a little and now qualifies through the expansion. So it's not clear that there are a whole lot of new people as much as movement in the Medicaid role.
Well, but that's certainly something we should be able to tease out with the data that we have. If you have, ID numbers or, Social Security, whatever the proper ID would be to be able to tease out someone who was in one category in the first quarter, then got a different coverage eligibility in the second quarter, then we just drop them out of this analysis. And the remainder should be new enrollees who would have this similar kind of spending pattern. So that's, I guess, just the first question is I think that this issue is more than just looking at people who enrolled in the first quarter. The second question I have has to do with you concentrated in doing the reasonableness comparison on folks who moved between self-pay and Medicaid, but we also expected through this enrollment there to be some kind of crowd out where folks moved from a commercial insurance plan over to Medicaid. Did you look at any of that charge movement at all in this process? And shouldn't we include that in terms of a reasonableness test if, in fact, there was a greater growth in Medicaid than just the movement from self-pay?
It's minuscule.
The way I understand the analysis, that they're looking at anyone who came in the first quarter, regardless of where they came from, commercial, Medicaid, or wherever, and looking at the utilization. So I think, if I'm understanding you correctly, it's captured in there.
Well, I understand for the $220 million, but I'm suggesting the reasonableness comparison of $244 million is based solely on the movement from self-pay to Medicaid, not self-pay and commercial to Medicaid. And if that was a bigger number, what would you then say about the reasonableness of the $220 million? So that's the second question I'm raising. The final one, and I defer to the hospital folks sitting here because I've had this raised as as they're looking at some of the uncompensated care matching we're going to talk about shortly, is just some of the crisp data accuracy issues that are being uncovered. And so I understand we shared data with the hospitals for purposes of doing the UCC analysis for them to check that data and confirm it with their records. Are we also planning to do that here for this calculation? That the crisp analysis that you're doing here and the matching that you're doing here, they'd be able to track that back to their own records to see if that was happening there as well.
We weren't planning to share this piece with the hospitals. It crosses hospitals as well. See later on, the growth is very different from hospital to hospital.
Sure.
Since we were looking at all utilization by these people, it's not so much a concern about which bucket the expected payer was, which was the issue with uncompensated care.
Yeah, I just would chime in here, and I know that you had a meeting with some of the folks from Frederick on Friday around just the data. One of the things we looked at is in our own decision support systems, what we had as brand new medical record numbers to the system that were Medicaid, and so we used different data pulls from that standpoint. We're just getting pretty different numbers, as you know, and I do think that we want to figure out how to reconcile those, and some things that don't show up as Medicaid but were in fact patients that were paid by Medicaid. So their financial class didn't show Medicaid, but the payment source was Medicaid. So I do just want to echo what Mike's saying, is that I think we should be sure that we've got the right population before we start making the adjustment. And I know you met with them and you're taking those points in, but I'll just want to
I just want to say, Mike, if we included the commercial in here, it would actually lower the Medicaid growth in the state. So right now it's showing at $218 million. If we include commercial as the change in commercial as a subtraction, we'll go in the opposite direction. So we would conclude that the growth was under $200 million if we took the commercial reduction out of the picture. So I don't really think that I mean, there is some shift. There may be some shift from commercial to Medicaid, but those people, in large part, were actually using the system to some extent before because they were coming out of an insured situation. They're coming into an insured situation, so they were already using the system. I don't think we're going to find a lot of growth, and actually it might show that we need a lower number if we actually include them in the calculation. And I think, at least I think I'm remembering the net analysis on woodwork growth is like 40,000 people. It's not a huge number of people. And if a lot of them are coming out of commercial, it's not going to have much impact on utilization for the analysis. And all we're really trying to measure is the impact on utilization.
Right.
And for this
again, I was
analysis.
just making a comment on the reasonableness check
Right, but
that you had on the previous page. I wasn't commenting on what the increase was for Medicaid.
But it would actually lower the increase. So it would, because if commercial were added, if the reduction in commercial were added to the bottom line, then it would actually say Medicaid went up $534 million, but self-pay, charity, and commercial went down by X million, and there is a decrease in commercial. And then the net would be under $200 million, and so then we would actually be accounting for more than 100% of the total dollars in our use analysis. So I think it actually cuts in the other direction. I just wanted to clarify that when you include commercial, it cuts in the other direction for the overall reasonableness of the analysis on slide 4.
just to comment, I was curious, on slide 5, is this calendar year quarters?
Yes, calendar year.
And there is a concern that I would agree with Mike on just using one quarter, just because there was some ramp up of being able to enroll Medicaid recipients that hospitals shared with their, like in our case, the local county is funding some dollars to help with Medicaid enrollment. So I think there might be some changes because of the way the timing works. But, and then secondly, just looking at which, you know, again, just coming back with the little bit of work that we did, looking at just what were brand new medical record numbers to the system. So it wouldn't matter what they were beforehand, but they're brand new, we've never seen that patient before, and using that number as, you know, the population change. That, I just think that that creates a database of folks that have come in that are Medicaid, and it's not necessarily being reflected equally.
But it could also be reflecting somebody who just had their first baby. You know, that there's a lot of, in the young population especially, there's a lot of, 90% of the people never hit the hospital. So there's going to be a lot of new, every time somebody gives a birth, it's almost always a new medical record number because they only use it when they have a baby. They don't use the hospital any other time. So you're going to get a lot of new medical record numbers for things like birth.
Yeah, but just to the last point, and then I'll move on. But how is ED? One of the biggest areas we've seen is just the use of the ED for Medicaid over the other product lines we've looked at. We haven't seen a dramatic change per se, but the ED volume went up dramatically. So that's included in this.
The ED is included in the product line. I saw there was a not a huge, but there was growth in ED in the first part of the year, and in the fourth quarter it actually was negative versus the fourth quarter of the prior year, so it really dropped off. Just on the Medicaid enrollment issue, so I have the enrollment for March end of the first quarter. Total enrollment was went up from there to December of 14 by 36,000 total Medicaid enrollment. It's over 1.2 million people. So there wasn't a massive growth in Medicaid overall from March to the end of the year. I mean, 36,000 over 1.2 million plus. So
it kind of depends on where it falls, right?
right. I mean, different hospitals have different
overall
growth.
versus some of the components. Yeah.
I'm sorry if I'm, kind of backtracking, but I'm losing in all this discussion. I'm losing track of what the policy implications are of this discussion.
I think we're just about ready to get to that, but basically, we did not fund any money in rates for Medicaid utilization expansion, but we left excess UCC in rates. We lagged the UCC adjustment in rates so that there would be money to fund some utilization expansion. And so now we're trying to get a look at, okay, how much utilization expansion do we think is an ongoing as opposed to a pent-up demand that dissipates? How much do we think is ongoing? And we've used CRISP data to help us look at that. And so even though we're arguing around the edges, I would tell you that this is one of the most sophisticated analyses that I've seen. Most states are trying to look at it 2 or 3 years behind using MEPS data or some other equally tortured approach to figuring out what happened. But so this is really current data that we used Medicaid IDs from CRISP and the HSCRC data to look at what services were provided to these folks in the prior period before they had the expansion coverage, no matter who paid for them, and what services did they use after the expansion. And I don't know if I can't remember if you were here the last meeting, and we were saying that we were excited because we were actually seeing that they used some services that they might not have had access to before. But they've used them, and now the utilization is falling off. And that's also consistent with what some of the actuaries said we should expect to see in the data is what we're actually seeing. So anyway, that's high level where we're headed with it. So now we were just getting into where we were headed with it.
Before you get into this, where we're headed with, just an observation. I read a study last week where the incidence of diabetes is increased in the states of Medicaid expansion and not in the states without Medicaid expansion. And that really doesn't mean actual incidence. It means we're just finding more. And you can pick up and say like a cancer diagnosis where you may have a pent-up demand spike, but then also more of a leveling off, but not to a really tailing off because of the ongoing nature of, say, cancer treatment. If you picked up here diabetes, you're probably also going to capture some where there's pent-up demand getting some immediate problems fixed, but then probably maybe not a sharp drop-off until the diabetes begins to get really controlled in the outpatient setting, if you're going to have more interaction with an inpatient setting in that particular diagnosis, too. That's an underlying thing that you may be seeing in cardiovascular. If you started to see it in kidney disease treatment or something, you may begin to start to see, what is the underlying problem of these people. Even some of the orthopedic surgeries, the joint replacement, may be due to obesity on the weight-bearing joints that may have an underlying also comorbidity of diabetes. So to begin to think about where the trend is, it's going to go plummet down or just kind of level off to more of a chronic care until it gets managed in an outpatient setting.
So if we look at slide 9 up on the screen, our proposal based on the data we reviewed was, and what we're thinking about here is what should we do for fiscal 16? Should we make an adjustment to the fiscal 16 rates to build in some money into hospital rates to reflect that there's a certain amount of this volume that's going to be ongoing? Given the trends that we saw over the course of calendar 14, we looked at quarter 4 as maybe the best approximation of the ongoing utilization. So that was roughly 18%. And we tweaked it a little bit because charges at hospitals were flat in that fourth quarter, so it was a little bit artificially low. And there was also a couple of tweaks related to hospitals that had sort of temporary rate reductions in calendar 14 that might have impacted the numbers. So we increased 18% to 21% to take into account some pricing issues. So then, if you look at the third main bullet there, we came up with a rate adjustment of $57 million. How we did that is we took the calendar 13 base, which was $542 million of charges to this group of people. We applied the 21% inflation, and then we applied a variable cost factor of 50%, which is our standard variable cost factor, and that produced a $57 million adjustment. That's sort of our thinking, is to add $57 million to the hospital rates for fiscal 16 to capture the ongoing impact. In terms of allocating the money across the hospitals, we looked at the actual growth that each hospital has experienced over the course of the year, calendar 13 to calendar 14, and we just allocated that $57 million based on that, on the growth. So each hospital in the end got 26% of its growth for the full year, and there is an attachment, first attachment that shows by hospital what those numbers would be. So if a hospital for the full calendar 13 versus 14 went up $1 million in Medicaid growth, the adjustment for that hospital would be 26% of that growth. So we had 57. We sort of decided statewide there was $57 million to allocate, and it's just $57 million divided by the total growth. So each hospital gets a sort of a fair share of its growth.
The other way to come at it, just from a thought process too, is that the growth was 42%. So half of the growth is 21% at 50% variable. That it comes, that's really what the math works out to. So that's another way of looking at the math.
Hey, Donna, this is Raymond.
Hi, Raymond.
Good morning. I wonder, instead of using charges, should you use where the growth in the lives occurred? You used the first quarter, and you looked at people who were eligible, I guess, or newly eligible in the first quarter, as opposed to charges, because charges could be a function of all kinds of things. Wouldn't you want to have the money follow the population?
As sophisticated as we are, we're not that sophisticated yet. And what we actually saw is that it was actually very interesting. People didn't necessarily stay with the same institution 100% of the time because they were getting some different services. So we did actually see some of this pent-up demand where people sought services at hospitals that they might not, that they might not seek on an ongoing basis, perhaps. But we did actually see different patterns come into play, and I don't think that we're sophisticated enough to do a population-based analysis with it. Maybe we'll get there one day, but it was a very big change in a very short period of time, and a lot of movement of patients going on.
Yeah, just a comment. I do think this is an incredible analysis. I mean, it really makes use of the great data that the state has, and then also linking into the CRISP information. And this is as good as it is throughout the rest of the United States. I mean, compared to the Ouija board methodology used elsewhere. So just wanted to make that comment. I think it's great.
Mike,
Yeah, I'm just going to go back to the number you raised, 36,000 people who enrolled in the last 3 quarters of the year. If you take that 36,000 on top of the 114,000 new non-PAC and 98,000 PAC enrollees, that's suggesting that 15% of the population of the total growth in enrollment during calendar 14 occurred in the last 3 quarters of the year. So to me, if I'm looking at this analysis, I would say, crisp matching issues aside, we've understated what the adjustment should be by that 15%. So that's just...
But we didn't take anything out of commercial.
Again, I understand that, but what I'm talking about here is just looking at the Medicaid piece, the way you've done this would suggest that we haven't accounted for that population who enrolled over the last 3 quarters of the year. That's all.
A lot of the people the increase, if you look at woodwork, they're people that may have come out or likely came out of commercial. Some of the woodwork people came out of commercial. They were using services before, and they're not as heavy hospital users as other enrollees because they're younger. And the only thing I'd like to put out too is there was one adjustment made to UCC in the last year, and it probably didn't account for all the UCC decline in 2014. And we're talking about changes that will become effective in July of 2015. So in essence, we were probably paying more in the UCC calculation than we should have been in this last calendar year in the first 6 months. So, this is something I think that we are continuing to look at and monitoring the volumes and the adjustment rates.
All right, we'll move on to, just one other thing on this. We also, I'll talk about it while we get the slides set up there. We also noticed for border hospitals, there was, a lot of the neighboring states also had Medicaid expansion. So we looked at the trends for a lot of the border hospitals in terms of growth in Medicaid, and there was some observed growth in the D.C. suburbs and Western Maryland in particular. So we identified the growth in those hospitals for out-of-state Medicaid, and are proposing to give them also 26% of that growth. And the next slide just shows what those adjustments would be for hospitals. It adds about 2.7 million additional for Medicaid utilization. Particularly you can see in Western Maryland there was a significant adjustment. All right, so that's it on the Medicaid expansion. The next topic is uncompensated care. Basically, we just wanted to update you on most of this data that I'm going to present was presented, I believe, in the January meeting, actually, but just refresh people's memory on where we are on uncompensated care. First of all, in previous years, we would update the regression analysis and try to predict the uncompensated care levels. Because we had this major expansion in the middle of the fiscal year, it's really difficult to update the regression. So we've been proposing to just use the same results of all the regression analysis that was done last year and make one tweak to last year's analysis. Last year there was a prospective adjustment made related to the PAC population gaining full coverage. There was an estimate of how much that would reduce uncompensated care. That number was about 166 million. So it's taken out of uncompensated care. For fiscal 16, what we're proposing is replacing that PAC adjustment with an adjustment for the whole Medicaid expansion. What did we actually observe over the year? It's the total impact. So this analysis is around what is that appropriate number. So the way we went about doing this, to refresh memories, is we compared calendar 13 first 6 months to calendar 14 first 6 months data, looking at the trends in self-pay and charity. If we, in the data, the case mix data the HSCRC receives, there's an expected payer for each charge. So we looked at self-pay, charity as sort of the people who were uninsured in 2013. Initially, we were just going to use that data, but we got feedback from the hospital industry that Medicaid pending cases, depending on the hospital, some report them as self-pay, charity, others report them as Medicaid. So we did a more sophisticated analysis using CRISP and Medicaid enrollment files to literally match up anybody who had an expected payer of Medicaid, self-pay, or charity against the Medicaid enrollment files and identify the actual charges that were associated with someone who was enrolled in Medicaid versus those that were not associated with someone in Medicaid. Just overall, when they did their analysis, they expected payer for charges that they identified as someone with a Medicaid enrollment period. You can see, for the most part, there were people with an expected payer of Medicaid. The bulk of the remainder were people who had an expected payer of Medicare, which makes sense because these were likely dual eligibles who would have been eligible in both programs. So to give you a sense of where they identified the people coming from. In terms of the results of the analysis, if you kind of look at the chart there at the bottom of page 16. So we started with the self-pay charity charges in our case mix data, which was for that 6-month period in 2013 was $357 million. The 6-month period in 2014 was $183 million. So a significant drop-off. And then we made adjustments based on the CRISP analysis. We removed charges that had been coded with an expected payer, self-pay, or charity, but were associated with someone who was actually enrolled in Medicaid at the time of discharge. So that took $75 million off of the number in 2013, $27 million off in 2014. And then we added charges to the self-pay total that had an expected payer of Medicaid in our data, but didn't have a match in the Medicaid enrollment files. So the person didn't appear to actually have been enrolled in Medicaid. We added those numbers back in 2013 and 2014. And all that comes together with sort of a revised total self-pay charity for each year, $446 million in 2013, $296 million in 2014. Again, half a year each year. So we had a half-year change of $150 million drop in charges that related to self-pay and charity. So we took that number and just annualized it by doubling it, which gets you to about $299 million annualized decline in self-pay and charity. And we compared it to the adjustment that I mentioned before that was made in the fiscal 15 rate tax adjustment, which was $166 million. So we're proposing to make an additional adjustment in fiscal 16, take out another $133 million. Just the difference between what was already taken out and the observed decline in self-pay charity. And we looked at this. We get monthly data from hospitals. It's unaudited, but where they estimate what their uncompensated care for the current fiscal year is. So this bar chart, the left-hand side shows you the policy, the UCC that was budgeted for fiscal 15, which was statewide with 6.14%. Through January, the actual reported uncompensated care is about 5.2%. So this really supports what we saw in our analysis of self-pay charity, that the uncompensated care levels that were built into fiscal 15 overstate what's really happening in the field. The next slide just shows we then made a couple of hospital-specific adjustments. There were a few hospitals that had significant changes in prices from calendar 13 to 14. So at 5 hospitals, we did a little bit of price leveling to do a fairer apples-to-apples comparison. There's one hospital where their data, I think by their own admission, doesn't make a whole lot of sense, and we're working with them to sort the data out and try to come up with an appropriate number. And then for out-of-state Medicaid, there was an issue. Some hospitals report their out-of-state Medicaid with an expected payer of Medicaid, which is supposed to report it somewhere else. They reported it along with all the Maryland Medicaid patients. So the problem with that was when we did the CRISP analysis, they were comparing these people to Maryland Medicaid, and they were finding a bunch of people who they were calling self-pay charity, who in fact were likely being paid for by another state. For hospitals where the change from 13 to 14 in this out-of-state Medicaid was negligible, they were about the same amount, it didn't really matter to the outcome. But there are some hospitals that saw significant growth in their out-of-state Medicaid, and so we were essentially overstating their calendar 14 self-pay charities. We're counting all that growth as self-pay. So we made some adjustments for a handful of hospitals to capture that issue. And there's a second handout in your materials. It just shows, based on all of our analysis, what the uncompensated care policy by hospital would be for fiscal 16. Statewide, it's about a 5.27% uncompensated care level. You can see for individual hospitals where it is and where the hospitals were for fiscal 15. So that's mainly for folks' information. We do have a number of hospitals that are still looking at the data. For the most part, the hospitals we've heard from seem to be comfortable that the trend that they're seeing is appropriate. There are at least a couple of hospitals that we're continuing to work with to work through the data. And some we have not heard from yet at all. Any questions on that? Okay.
Just a clarifying question.
Sure.
So column D in your, I guess, attachment 2,
Yeah.
that's the net of adding back the, I forget, $57 million, then less the UCC adjustment?
No, the 57 million is not in here at all. The column D is both the 133 PAC or 166 PAC that was taken out last year and the 133 million of additional money. So it's essentially showing you how the 300 million.
Thank you.
So the $57 million is a contractual adjustment because in all of the global budgets, we said that we would look at the impact on use. And so we're not, they're kind of separate issues. One's for use and the other is based on just pure uncompensated care.
Thank you.
So again, if I'm reading,
They don't net each other. No. We're saying there's an increase in use that we would expect, and there's some ongoing that we're saying needs to be funded. I mean, that's our best estimate right now, that there's some level of ongoing use that needs to be funded. So that's going to be added in through to the global budgets under the contract provision. That's what we propose to do. And then the UCC is a different thing. Yes.
So if I'm reading this, then the additional reduction, prospective reduction for 2016 would be 87 basis points, 0.87, the difference between these two columns?
Correct.
Was, as it related to the uncompensated care, was that also done with a variable cost factor? So I just wanted to know, was one done at $1 for dollar and one's done at 50 cents on the dollar?
One's cash, so cash is cash. So UCC is a cash-based adjustment. So you're getting the cash in, you're not getting the cash in. So that's not about variable cost, it's about cash.
Okay. All right. Going back to the slides, Slide 21. We promised we would show you this data. The Commission asked us to start collecting this year information on write-offs and recoveries. This came out of last year's UCC policy. So we've collected 12 months of data, all of calendar 14, from hospitals. So the data that they've reported is any write-off or recovery that occurred in calendar 14. So a lot of this data relates to prior years. Hospitals were still writing off prior years. Their recoveries would go back many years in the data that's been submitted. I would also caution that there are a few hospitals where their numbers are still not making a lot of sense relative to all the other hospitals. So these numbers are sort of a first take on the data. We're still working through a few issues in some hospitals that will change some of the overall picture here. But what we found is, starting at the top of the page, the write-off amounts that were reported were essentially about $1 billion. The largest share, $586 million, was associated with self-pay charity or Medicaid expected payers, $265 million with commercial, $116 million with Medicare. So, nearly 60% associated with self-pay charity or Medicaid. We also show the total billed amount related to those write-offs, and then the write-off as percentage of the bill. Now, this is the area where there seems to be a data issue with a few hospitals. There are a few hospitals reported a very large billed amount and a very small write-off amount for the self-pay charity Medicaid category, and they're reporting 20% write-off in those things. Everybody else is closer to 80%. So they're pulling down the overall percent to 48%. I think when we clean the data out, it'll be more in the 75 or 80% write-off as a percentage of bill for self-pay charity Medicaid. You can see commercial is about 16%, Medicare about 9%. And then in the middle of the slide, we just show you the recoveries by expected payer. The largest share recoveries coming from commercial, which seems to make sense. And then we just netted the recoveries off on the bottom and restated the data net of recoveries. You can see the commercial share of the total write-offs dropped after recoveries down to about 19%, and the Medicaid self-pay charity slide. So this is the first year of data. Since we only have 1 year data, it's hard to do any trend analysis, but it's really building a baseline that we'll be able to use in future years to see whether trends are changing and hopefully be built into some of the regression analysis we do in the future. No denials, just write-offs. We are collecting denial data as well. We got some initial submissions. There were a tremendous amount of inconsistency in the data we received between hospitals, so we're continuing to work through that. I hope we'll have in the fall some cleaner denial data that we can start presenting and, again, start tracking that going forward as well. Any questions?
Joe, I have a question about the Medicare write-offs. Is that mostly related to the beneficiary cost sharing, or can't you tell?
We can't tell for sure, but our expectation is that it's related to the beneficiary cost sharing, and that 9% as a share of the bill seems consistent with beneficiary cost sharing in Medicare.
Thank you.
So the Medicaid piece, it's not the denials, it's the expected payer, and ends up not being the expected payer? Is that what's in the Medicaid number?
The Medicaid is any expected payer of Medicaid self-pay charity. We lump them together. So it's whoever was written off. Some of the people who were coded as Medicaid may have been Medicaid pending and ultimately were rejected by Medicaid as not eligible.
Okay, I just want to make sure that it's not denial.
It's not. We're not collecting denial. That's just for write-off amount. We've got a whole separate reporting going on the denials that'll get into that issue. I need to look. I'm not sure if we got it at that final level in this reporting. We can check. On the denials, we can. Actually, the data that we are asking for in denials, we'll break it out by MCO versus fee-for-service.
we really shouldn't have any Medicaid bad debt in theory because there's no cost share, but it just would be whether something started out as the Medicaid and it got written directly off to bad debt when Medicaid didn't come through.
Right. The other thing it looked like might be happening on Medicaid is there's a few hospitals where it looked like they were, if Medicaid pending went on a while, it got written off, and then they may have gotten paid in full later when Medicaid said this person is eligible, but it initially was showing up as a write-off because they had given up hope. Okay, now to a simple topic, the update factor. Wanted to start off the update factor discussion with sort of our latest balance update sheet, which is the third attachment. We'll pull it up. So our approach to the balance update is to try to piece together the sort of factors that we think are driving costs at hospitals, make sure we've got an appropriate inflation adjustment, make sure we have accounted for volume, build in some money for the Medicaid utilization growth, and then make the appropriate adjustments for uncompensated care, as well as some of the various assessments that change from year to year. And kind of come up with a good base number that this is sort of the minimum we think is appropriate to cover hospital costs. And as you'll see, we've left blank the issue of infrastructure and whether there needs to be some sort of additional infrastructure adjustment or something else going forward. This is sort of kind of a base set of numbers. So let me just walk you through this really quickly. A lot of these are similar to what you've seen in previous meetings. Based on the global insight information on inflation, we're still at 2.4% for an inflation factor for fiscal 16. The volume, we're intending to make a 0.57% adjustment, which is based on population growth, estimated population growth in the state. We've built in the Medicaid expansion utilization, the $57 million that we just talked about, which is about 36%, 0.36 percentage points. Infrastructure is holding a sort of a blank. There's a small adjustment for the Germantown Holy Cross Hospital that opened mid-year in fiscal 15. We're just annualizing that impact. Then the other adjustments, we have a 0.5% set aside for unknown adjustments, as there's certainly issues that come up during the year, individual hospitals that run into issues that they come to talk to us about. So we're sort of holding some money there to make adjustments that are unforeseen at this point. And then some adjustments related to shared savings, which have a net 0.2% coming out for shared savings. So all of that sort of up top part comes up to a net increase attributable to hospitals of a revenue of almost 4% on a per capita basis. That's excluding the Medicaid adjustment, that would be 3.04%. Including the Medicaid adjustment, about 3.4%. And then there's the components of the revenue change that we sort of see as not really impacting a hospital's bottom line and sort of outside of the control of the hospital. The first is the uncompensated care, which we've netted as a differential, and you can see the adjustment there. And then based on the action so far in the General Assembly, it appears the UMHIP assessment will go to 0 for fiscal 16, so we're zeroing that out. And we're also removing in fiscal 15, there's $15 million for a one-time BRFA adjustment that was allowed for regional collaboration and care coordination activities. We're assuming that will go away in fiscal 16. The legislature authorized that as kind of a one-time thing. So when you take all those decreases, you end up with a net revenue growth of 2.65%, per capita growth of a little over 2%. Questions on that sheet? Okay. So the next thing we did is try to look at the results of what we just showed you in terms of our sort of two key financial tests under the contract with CMI.
I'm actually sorry. The set aside for unknown adjustments. Do you have an estimate yet of how much of that set aside, which was 0.5% for 15, has been spent so far this year?
There's still some ongoing discussions with some individual hospitals, so we don't have a good number yet.
Okay, thank you.
Okay, so we wanted to see how this analysis compares to sort of the constraints of our all-payer waiver. So we looked at it both in terms of the all-payer and then in terms of our Medicare test. Slide 24 looks at the all-payer issue. A lot of numbers on the page, but I'll try to make this relatively simple. The first line in column A is, or row A, is showing you the maximum per capita growth under the all-payer that we could have, which we're supposed to have average annual growth of 3.58% a year. So we show actually 2.5 years here, calendar 14 through fiscal 16, so through June of 2016. And it says that the cumulative growth that's allowable through June of 16 is a little over 9%. The next line, row B, shows you the actual experience for the first half of calendar 14, the staff projection of where we're going to end up in fiscal 15 of about 1.78% growth, and then we've filled in that pro forma FY16 column just the numbers that you just saw from the draft balance update sheet that we went through. So all of that would say that we would have cumulative growth over the 2.5 years of about 4.47%. Now, we think that the 4.47% is somewhat artificially held down by the changes to uncompensated care and MHIP, which are, as you've seen, we're going down in fiscal 16 and both went down in fiscal 15 as well. So the cumulative impact of those decreases is about 2.44%. So when you add that 2.44% to column C, or row C, to row B, you end up with a sort of cumulative growth that we've used of 6.97%. So essentially what we're saying is the maximum we could grow is a little over 9%. With our proposals for fiscal 16, we think we're using roughly 7% of that capacity. So there is some cushion between what the maximum allowable is and what we're actually. Microphone. Can you put the microphone?
So when they do the analysis for the waiver, are they going to strip out the 2.44, or how does that work? I'm trying to figure out. I'm trying to track this.
Where is the they? We. No, CMMI doesn't do it. We do it. This is our test. It's not their test. So the 3.58 is really the all-payer Maryland test. So we're the they that you're talking about. All I'm saying is it's HSCRC who does the calculation. So yeah, we include actual charges in the calculation,
which is the 4.47.
Yeah, sure.
Any other questions, comments on this slide?
I just want to make sure, because I was trying to do the math. When you actually did the cumulative through the end of fiscal 15, it looks like you took half of the first column, half of that 1.13.
For the 6-month period.
Okay, thank you.
Barbara.
Hi, I think this is a very basic question, but the difference between either the 9.21% and the 4.47%, just generally speaking, how much do the hospitals get to keep in terms of that percentage difference, or if it's better to do the comparison between the 9.21% and the 6.97%, just in terms of the cushion and where, what the hospital
They didn't keep any of it.
They what?
They didn't keep any of it. We're measuring what they actually got, or what we think they're going to get by the end of the year, versus what the maximum amount that they would have been allowed to get.
Okay. Okay. Well, is there another, and maybe this is for another time, because my very rudimentary understanding is that there is some margin between what is allowed, which is our 9.21%, and what's spent in terms of, maybe I'm wrong, the hospitals being able to reinvest that in various areas.
The issue is how much money is saved inside of the 4.47 for utilization decline.
Okay.
And I think this actually goes back to what I would call a misperception in the doctor community, that there's some huge amount of money that's caught up in global budgets that they're not getting. And so we hear it outside of the state or from other people. Well, you know, aren't you just capturing all that savings? And it depends on how tight the lid is. So when we have a lid that's based on inflation and population and some of the other things here, then we actually look at that as the 6.97, because the other pieces that are reducing costs are not part of the profit stream of the hospitals. They're profit neutral, more or less. But you know, we think that's a pretty reasonable cap, especially in the short run, while people are trying to reinvest the savings. So it doesn't give you a picture that there's some huge amount of money being captured and held in the hospitals. Maybe over a longer period of time as utilization declines. And if you see, you know, with the TPR hospitals, if they have a longer period of time to invest and save, it happens over a longer period of time. But I think there's this illusion, I'll call it an illusion, that the doctors have, that so much money is just being held in the hospitals. And I think this is really showing that that's not true. Maybe that's, Mike's happy that I was making that argument, because he's...
No, I think it's a very important point to understand that if we did nothing further at this point, what this chart is saying is that the actual hospital spend for the first 30 months is only 4.47% per capita over 30 months. And take into consideration that going into this model, we were running at 6.8% per year. So that's pretty darn impressive that we've constrained the model over 30 months to 4.47% when we were running historically 6.8 over the 10-year period going into this model. So I think that's a huge accomplishment on everyone sitting around here on this table. Now we can argue over the last 3 rows of this chart and whether some portion of that needs to be baked back into the system to allow for necessary infrastructure investment and other strategic things we need to do to be assured long-term of savings under this model from further reductions in unnecessary and inappropriate utilization. But right now, the model says if we did nothing further, 4.47% over the first 30 months.
Well, that's helpful, but I think offline we should spend some more time and maybe at least help think through this and
make sure we figure out how to tell the story correctly,
yes,
so that people
yes,
aren't thinking that there's some huge trial of money building up in the hospitals from global budgets that isn't getting put to use.
I think it's, yes, an important thing to really understand thoroughly. So,
Just a quick point. I think it is really a remarkable experience and performance. I would also just point out that nationally, though, the trends are running at about gross domestic product growth. So we're in a relative to the historical performance, this is really impressive. Relative to sort of the new order, things are growing at about GDP growth nationally. So we may be sort of in a tougher comparative era, but still, this is not to diminish the great performance that the system
achieved here. Donna, about Dave's question of the we maybe HSCRC now, but at some point CMMI is going to do their own calculations, right? And they're going to determine whether Maryland's made their, fulfilled the agreement in the waiver.
Well, they audit our calculation for the all-payer, so it is our calculation. They audit our all-payer calculation or review it. But they have the savings test, which I think David will get to next here. But so that's a different calculation. But and they're producing that calculation, and we're auditing their calculation. So I think, but on this one, we're in control of the numbers, and we have I think we have a very good accounting system that's updated monthly to do the calculation.
And how is the phenomenon that Bob just mentioned affecting this? I mean, if overall health spending trends go, continue to be really slow, does that affect the benchmark at all, or is our benchmark fixed at an amount, or does it change as national trends change?
Well, our benchmark is fixed, more or less. It could be changed in year 4 and 5 of the demonstration, but then we could also have a spike in inflation and wage inflation, for example, coming down, in year 4 and 5, and we may need to go over 358 if we have a spike in wage inflation that we need to pay folks when we get more boost in the economy, and there may be other factors that need to be adjusted for at the other end. And we are focused on trying to understand how we compare to all-payer national trends. There are some, when we look at all-payer national trends, they actually do strip out these uncompensated care changes because they only look at the payment increases, and so the non-payments are not in the national number. So we have to strip that out to get a clean comparison. So that adjustment that we're making here does start to give us a cleaner comparison to national all-payer trends. So we're trying to work our way through that now. But that does, the UCC adjustment has to be stripped out to compare to national all-payer trends.
Okay. The second test under the contract is the Medicare savings test. The contract requires that the state generate about a minimum of $330 million of Medicare savings over the 5 years, and that was calculated essentially by getting about a 0.5% savings per year over the 5 years. How they came up with $330 million. The slide 25 gives you some very preliminary. We can't put enough adjectives to say preliminary, untested on this page, but sense of how we're doing. We've been receiving some data from CMMI, and the national data for calendar year 14, Medicare fee-for-service, appears to be growing by about a 0.5% on a per beneficiary basis. Now we are still working on kicking the tires on this data, so we're not fully confident in that, but that's what it appears is going to be the national trend for calendar 14. The Maryland trend, we're relying more on our HSCRC collected data at this point, because again, we're really looking hard at what we're getting from CMMI. What we've reported for calendar 14 for Maryland Medicare beneficiaries at Maryland hospitals is a decline of 1.1% on a per beneficiary basis. So it appears that we are going to beat the national growth rate by about 1.6 percentage points in the first year. And again, all the caveats I said before about preliminary and untested, but that seems like a likely sort of minimum differential. So, you know, a positive, at least positive signs so far for our first year performance. So then the question becomes, what do we want to do for fiscal 16 in terms of thinking about what is an appropriate target Medicare savings? Our staff are proposing to continue to try to beat the nation by about a half percentage point, which is sort of the underlying concept in the model contract. There's a few reasons that we think it's particularly important to be cautious here and shoot for that 0.5% savings on an ongoing basis. One is I'll get into in a minute, the actuaries at the national level have been overstating the Medicare growth nationally in recent years. They haven't been very good at predicting the growth rate. So if we're sort of targeting national growth rates, we need to take those growth rates with a grain of salt because they've been high initially. And because of that, and you know other things that could happen in Maryland, we want to preserve some cushion or hedge against poor performance going forward. And we also think it's important to build on our first-year success, build goodwill with CMMI, as we certainly want to retain the waiver and get, you know, in the long term. And we think continuing to show that we can generate savings is important to building that partnership and goodwill.
Yeah, and Medicare did make a negative rate update for overall the rates went down for inpatient on October 1 from the Medicare DSH adjustment. So you know, we're really not far into that process here, but it is an ongoing issue that we're concerned about.
And what did they have a sizable number on outpatient? I mean, it was over 2% from what I recall on outpatient.
My recollection is around that range.
Okay.
Yeah.
So
That was rate increase, not rate and volume. That was just rate growth. Right? So I just want to make sure we don't base this all on what happened on the inpatient side.
no, we're not. We have a balanced figure.
So the next slide showed you some of those national estimates of growth. So we have the Office of the Actuary estimates to show you what they estimated last February for a 5-year period and what they revised those estimates to this February. You see for calendar 14, they revised it down slightly, a couple of 0.2%. But again, I would note that the data that we're receiving from Medicare shows that for calendar 14, they had growth closer to 0.5%. So even their most recent estimate is significantly higher than what it appears we're seeing. And then calendar 15, again, you can see there was a substantial reduction in their estimate going from 1.7% to 0.3%. So just sort of highlighting there's a lot of variability here and uncertainty in there.
Why is there a difference between the 1.5 and the 0.5, their estimate and our estimate?
We don't know completely, but if you consider the purposes that they're doing these estimates, one is for the President's budget, and then the second is for the Medicare trustees report. So the only thing that we can say is when they're doing the President's budget, then I wouldn't suggest that this is the case, but if the projections of cost are high, and then they're getting into the cut section with the PPS office, and they're saying, oh, the trust fund is in trouble, we need to cut hospital rates. It's a little easier if you start out with a high number and cut it down than if you start out with a low number and you can't make your point. So, or you know, if you're going to the Medicare trustees and saying, oh, we're going to go bankrupt in 2027, it's easier to get Congress to cut things than if you say we're going bankrupt in 2040. So I don't really know if that's the case. The other thing that just talking with the actuaries, these are unprecedented low changes in use, and they are reluctant to project these really low growth rates going forward. So part of it's maybe the reluctance of the Office of the Actuary, and then in my more Machiavellian thinking, I wonder if it has anything to do with the budget process. But you may have some insights into that too.
Putting aside the Machiavellian theory, I think if you look at, especially if you look at the 2014 number that HSCRC has, which I think is closer to the actual change. I don't know. I mean, I don't see a good explanation for the 1.5% number there for 2014 since they knew better than that. But you can see that in the out years, even though they've had a historic change in the trend in Medicare spending, they're very reluctant to change their projections in the out year. And that's generally, I mean, you have to understand actuaries looking in the future have no better crystal ball than
I can understand that for the out years, but 2014.
Yeah, that I don't understand. That I don't understand. But and that, you know, there may be some. I don't know. I've seen lower numbers that put out, so it's not like they're hiding those numbers. But you know, at some point, and you saw this with the Congressional Budget Office too. For years, they, you know, for several years, they were kind of hiding behind, well, it's only the recession that's causing the slowdown in Medicare spending. And then at some point, they decided, well, this must be real because the recession's starting to be over, and we're still seeing these slow increases. And you've seen a cumulative, like, more than $1 trillion decline in the 10-year estimates of Medicare spending over, you know, by CBO. And I think the CMS of the actuaries probably just a little slower to accept long-term slowdowns than CBO was.
And also, just in the out years, if you look at the potential for more wage growth, inflation growth, et cetera, I think that keeps a cushion there for them. But that shouldn't affect the near term.
You know, one other piece, I'm wondering, this is just fee-for-service spending, correct? These growth rates, not Medicare Advantage weighted in here in any way? Because one of the things I think we've begun to see is that a lot of the newer, at least nationally, Medicare enrollment is going into the Medicare Advantage plans. So the caution they may be building in here is they're expecting the remaining fee-for-service enrollees to be a sicker, more costly population, and that's perhaps some of the caution that I believe, at least in the out years, they're beginning to build into this.
It's true. The number that I've heard is that 50% of new Medicare enrollees are enrolling in Medicare Advantage, and you know, overall it's 30% of Medicare beneficiaries. So clearly the Medicare Advantage population is getting younger.
Okay, we'll move on to the next slide. The next slide sort of gives you an outlook of where we think we'll end up with all the numbers that are preliminary hold. So the first line there shows the projected national growth rate that you just saw with an adjustment for 2014 based on the experience we're really seeing. And then that differential that we talked about, we're beating we think we're going to beat the nation by at least 1.6 percentage points in calendar 14. And then our proposal is to shoot for about 0.5% savings in 15 and 16. So you can see the net of those, adding those two numbers together, you get the Maryland growth rate on the Medicare side to achieve the target savings. So it would basically be flat in calendar 15 and then 2% growth in calendar 16, and the resulting savings under our Medicare test if those numbers were to actually come to fruition.
The numbers on the bottom, they're not cumulative, are they? Or are they?
So those are the annual, the savings for that year.
That would be, again, the savings for that year. So you're saying by the end of calendar 16, we will have achieved over $300 million in savings?
Correct.
Right. Could you add a line to this chart? Because what I'd like to see reflected here is what the contract was anticipating or requiring for savings in 14, 15, and 16. because that's on a cumulative basis far exceeds what I believe the contract requires or allows. My recollection was, for example, there was no savings required in the first year, cumulative savings of $49.5 million by the end of calendar 15, and cumulative savings by the end of the third year of $132 million, where I believe you just said we're at the end of the third year over $300 million.
Right, that's correct.
How do the savings work? So in 14, we had a differential of 1.6%. And that's
right.
That's 9
Well,
million.
we don't know that for sure yet, but just
Right,
for
no.
this pro forma.
Actually, I'm thinking it's more like 180 million because I think the federal government's right. But in calendar year 15, is the differential then 0.5%? How does that equal 117 million in savings?
Because you're maintaining the savings you already generated, and you're beating them again, so you get an even larger.
Well, it's not cumulative.
It's that factorial kind of cumulative. So $1 saved in year 1 is $2 in year 2 kind of thing.
Well, it's, instead of beating it by 1.6, we're now beating it by 2.1 on a cumulative basis. That's the annual savings for that year. I got it. Okay.
Correct.
Okay. So you do have to add them together to get the equivalent. Okay, got it. Okay.
All right, so the next slide. So the next slide tries to convert all this information to what is the fiscal 16 growth to meet the target on the Medicare side. So we take calendar 15 and 16, you look at the far right, the Maryland growth, and we just average the two. In red you can see, so the fiscal 16 target growth would be 0.85%, Maryland Medicare per beneficiary. Last year there was a different statistic calculated that showed that you could basically convert the Medicare number at 2% and get the all-payer growth that allowed, that the Medicare number would allow. So we add that 2% different statistic, get to 2.85% all-payer per capita growth, so converting the Medicare to the all-payer. And then we take into account population growth. Total revenue could grow 3.44% if we were trying to meet this level of Medicare savings. The next slide just refreshes your memory on the different statistic calculation from last year shown there at the top, and then we show you the fiscal 14 data, which is relatively consistent with the average from 2009 to 2013. And then the final slide just shows you, so as we said, the all-payer maximum to achieve the Medicare savings that we just talked about would allow 3.44% revenue growth, 2.85% per capita growth. The balance update model we showed at the start of this would have revenue growth of 2.65% and per capita growth of 2.07%. Bottom line, our proposal thus far is well comfortably within the growth that's allowable to achieve the Medicare savings target. So there's some capacity, whether you look at it in the all-payer approach or you look at it from a Medicare savings approach, to do more than what is thus far built in.
Yeah, actually, just maybe a comment, because I'm looking at slide 30, the Medicare difference statistic. The data that we had through 2013 was 2.94. The Commission used 2%, and we ended up coming in the first year at 2.55. If you now take the 6-year average, it's just under 2.9, 2.88 in that range. So in terms of the way you've just described this model, if instead of using a different statistics of 2%, you use 2.5%, which is still within the range, but certainly much closer to what the actual experience has been for the last 6 years, and basically what it was for the first year of the waiver. And you then went back to slide 29 and added 0.5% in that to the difference statistic. That is, change that 2% to 2.5%. That means you could actually see total revenue growth of 3.94% or 3.35% on a per capita basis, compared to the model that you have right now of 265 on a total revenue and 207. So I would argue at the very least you've got an overstatement of, an understatement of the Medicare difference statistic and an understatement of what that difference is by at least that 0.5%. And that also assumes that from day one, the 0.5% allowance for unforeseen adjustments would also have been spent throughout the entire year, which hasn't been the case in the first year of this model. So there's that additional cushion as well.
Other comments? Thoughts? Okay, then we're done with the update discussion. It's likely we're planning to make a recommendation to the Commission on the update in May. The uncompensated care recommendation would be in this upcoming meeting in April.
And how about the utilization adjustment for the expansion?
At the global contract issue, we're going to brief the Commission at this coming meeting, but just include it in the update in May. So if there's no other questions on that, I'm going to turn it over to Steve to talk about regional collaboration.
All right, thank you. This is more in the category of sort of an FYI, an update. I know many people are very aware of the BRFA, particularly the regional planning grants, which we're going to focus on here. So just by way of background, the 2014, that's last year's BRFA, suggested that up to $15 million be used from hospital rates for statewide regional infrastructure and planning. And again, that was $15 million, and it would be an increase in rates to be able to access those dollars. So you may recall the advisory council that was established. They recognized the need for statewide infrastructure and care coordination, and they also said first you need to focus on meeting the new waiver test and to invest in a sustainability model. And some of the areas of focus were for physician alignment, which there are some items, gain sharing and shared savings, pay for performance things that are kind of in the works right now, but also to address the high needs patients, particularly related to care coordination. And there are really kind of three strategies around that. One is these regional planning grants, statewide infrastructure, which I should tell you the care coordination work group, if you don't know, met last week and now has a set of recommendations to bring forth to the Commission for some statewide infrastructure potential, at least initially about $12 or $13 million in how to improve kind of the how to share information and bring more providers, connect more providers. And then the evaluation and planning process to get resources to help keep this process moving. The regional approach, which I'm just focusing on really today, is necessary to really focus on some of the key needs of high needs patients and coordination of resources between hospitals, physicians, and community health. And again, that statewide infrastructure is sort of the platform to help support kind of these boots on the ground regional collaborations. On February 10th, the DHMH and HSCRC released an RFP for funding support for planning and development initiatives and operational plans for these regional partnerships. We've had several webinars, one explaining what the purpose of these regional grants are. Another, we've also put on our website a series of county data that folks can use as part of putting together their proposals, particularly geared toward finding out who the high needs patients, what are the high needs in your communities, and how to kind of address those, or what should be the focus of addressing those. We are, the idea here is proposals should be developing care coordination and population health priorities, looking at what resources are needed, and how those resources and strategies should be deployed, and how they also can be sustained. The applications are due on April 15th, less than a couple weeks away. Grants we expect would be up to $400,000 for 5 or more proposals. There's a total amount we expect $2 to $2.5 million, so we could provide some smaller, more smaller grants, or we could even, we've talked about the fact that we may marry some proposals together to try to broaden and provide, even more than the 400,000 if we see some very promising proposals. A review committee has been set up, or is being set up, and we're going to have probably next week or the following week an initial meeting to talk about what the criteria are, and then following the 15th, by the end of the month, we hope to have pretty much be close to having the recommendations so that we can get that before the commission. Some of the we expect what successful proposals will look like. Of course, it needs to support the all-payer model and the 3-part aim. It needs to be scalable so that these partnerships can demonstrate success and potentially broaden once in the future. Support coordinated action where there's currently no coordinated action that could, as a result, would increase cost and provide a not very patient-centered environment. And since DHMH is, integrally involved in this, we want to make sure that the LHICs are, part of the process. They kind of have the pulse of the community, and that's really one of the primary aims. And to align with other parts of the healthcare system, of course, physicians and community providers. But the bottom line is it needs to be patient-centered. We know hospitals have a lot of ideas, but there are a lot of places around the state where there are resources in the community, and we need to use those resources. It's not just a hospital solution. This is a community solution with all payers kind of rowing in the same direction. So that's what we're going to be looking for. We will. There is a staff recommendation before the commission as a draft, and we intend to offer a final recommendation at the at the April meeting, with the idea of increasing rates. We need to, for this BRFA money, actually collect the money in fiscal 15, meaning that once we decide what the rate increases would be, they would have to be applied over May and June for the full $15 million. The way that would be done would be, we believe, as an adjustment to the global budgets. There would be a uniform adjustment for the statewide infrastructure piece that all hospitals would share proportionally. And then for those winning bidders, there would be a separate adjustment just for that hospital, or if it's a collection of hospitals, those collection of hospitals would see that increase in the rate so that they can generate that funding. It doesn't need to be spent by the end of the fiscal year, but the planning grant piece anyway is the final report for planning grants is due in December of this year. So it would, that piece of it anyway would be spent over that period of time till the end of the calendar year. And that's basically it. Are there any questions? This is, as I mentioned, this is sort of FYI and update. I know everybody here is probably very familiar with this. Many people in the room may be involved with some potential proposals, but just wanted to let you know where we were.
Just a question when you said it didn't have to, I want to clarify that the dollars will come in May and June, did you say, of fiscal year 15, but the spending time frame doesn't have to be in fiscal year 16?
That's right, yeah. So
the
planning piece, which is about $2 to $2.5 million of this, obviously the end of the planning process is December. The final report's due in December. So those dollars would be spent and shared with pursuant to those proposals with the community providers over that period of time. In terms of the larger piece in the statewide infrastructure, the care coordination work group has been kind of budgeting and looking at, what priorities we should have for some of that connecting physicians and sharing data with different providers. Don't have really necessarily a timeline, but that would probably be a longer timeline.
Longer meaning 16. So it won't be spent in 15. I don't think we'll get a bill out to you. We might, but for a small piece of the 12 million roughly that would be for statewide infrastructure, we would expect that to be spent during 16. There's actually a much larger infrastructure funding requirement that was calculated by the care coordination work group, and we're getting that written up into a report now. We are looking, hopefully, for some other funding sources in addition to not just rates, but trying to see if we can find some money outside of rates to pay for some of the infrastructure. So we'll, but we will be carrying forward that recommendation and that report into the upcoming commission meeting. But it's just, it's over $50 million of infrastructure requirements for startup and connection costs, and then there's ongoing operating costs. It's going to take some time before we actually get a real solid budget on the ongoing operating costs.
And this $15 million, that was that built into that projection you gave us on the update for 2015 at 1.78%? Did that already factor this money in? Thank you.
And going forward with the rate adjustment that may be given this FY15 to certain hospitals won't count against those hospitals in the future for the request for future rate adjustments?
Actually, I believe there might be language in the BRFA that says that it wouldn't, like for an efficiency adjustment or something like that, would not affect them negatively in that way. Okay.
But it's spread like butter, so it's not really affecting comparative efficiency because it's being spread like butter, except for about 400,000, which really would be insignificant to any efficiency calculation. I mean, this is just in terms of infrastructure. The infrastructure that we're working with the work group on is just statewide infrastructure. It doesn't include regional or hospital local infrastructure, and we are hoping that the regional planning process will really begin to lay out, what is it going to take from an infrastructure standpoint to scale, to bring the model to scale. So that's part of the planning process that we're trying to have take place to get some numbers out there.
Donna, can you just briefly tell us what this infrastructure looks like in terms of this $50 million? What does it mean?
Sure. So just to when you see the report next week, and all the numbers will be laid out in it, but about $30 million out of the $50 million is to connect community-based providers to CRIS, to connect their EHRs So that would be the doctors, the mental health workers, maybe some case managers, and also the nursing homes. And so there's a large component of those providers who aren't connected. And the discussion said if we're actually going to exchange information and care plans and gaps in care among providers, we actually need to have them connected something so that information can be exchanged. So that's about $30 million of the cost. And then there's another chunk of cost of getting some data analytics infrastructure in place to bring in the Medicare data and also to use the existing HSCRC data to provide more timely and more complete information on patients with high needs so that it can be built into a care coordination process and so that it can help fuel the community-based doctors who are trying to build on the new Medicare fee for chronic care management. So that the chronic care management fee that Medicare started on January 1, if about a third of the patients could be enrolled in that, and 60% qualify, but if we got a little bit over 30% in, it would bring $140 million into practices in the state. And so that would be a really strong alignment model for hospitals and physicians to go after together to really try to build that model, which is focused on chronic care improvement and allowing doctors to spend more time with patients with chronic conditions. That would be a really great model to support. So that's been a lot of the discussion. And then the last piece is really building some viewable, we'll call it viewable care plan summaries so that the providers can learn about, for patients that have a care plan, that they can get some standardized views of that information so that as the patient passes from one part of the system to another, and that alerts can be sent when, for example, if a person who has a care coordinator, if they, right now, when they enter the hospital, maybe if the doctor's registered, they get an alert, but maybe the care coordinators can get an alert also, and folks can actually see the care plan that's a summary level of a care plan that's in place. And also working closely with patients and consumers to develop all of the processes that need to be put in place to assure that permission is given when needed, et cetera, and so forth. So going through the extensive processes that need to be put in place to make sure that we're handling the confidentiality issues appropriately. So it was a very 5-month process with long meetings and good participation from a number of folks, and I think it's a very good recommendation that will be coming out of that work group.
Exciting. Just one other quick question. Do we know, if this $50 million does emerge, I mean, would this effort be associated underage with HSCRC or somewhere else, or we don't know?
So the HSCRC would expect, the recommendation from the work group is that the administration of this effort would be done from CRISP, and that CRISP would be we'll call it effectively the general contractor, not that they would actually be doing all the data analytics, but that they would be the general contractor, because it really is not a government function per se. It's really to try to, similar to Chris' mission now, which is to try to do things collaboratively that will actually help the field when things that can be done collaboratively will result in a better outcome and a lower cost for the field, then that's what Chris focuses on. So this is really saying to use that focus that's already in place and try to build on that, and also that whoever the vendors are that are ultimately selected to perform work, they really need to be accountable to the providers, not to the HSCRC. So trying to build that accountability back into the customer, if you will. So that the thought process is that we're trying to help make sure that hospitals and other providers have the infrastructure they need to implement and administer the model effectively. And right now, the care coordination work group recommended that Chris be the entity that would help administer that process because of their historic role and their board structure and their mission.
So could you link for me the flow of, I guess when I was looking at the update numbers and you said, it's blank still on the regional collaboration, I just was thinking the numbers were going to come in next year. And so now the clarification that the $50 million is going to come in this year. What's the thought around the update topic here of regional collaboration? Is there some continuation that you're expecting that would come into next year? Something new? Just curious. It's the blank part of what you were saying here. It's got a topical area called regional collaboration. It's actually infrastructure. So just thinking about, is there some amount of infrastructure that needs to be funded? I mean, so that's what the open question is. Is there some amount of infrastructure that needs to be funded, and how should it be funded? On one hand, we have a regional process starting that won't be done on July 1 when the updates are coming out. So, I think that, the question is, well, how should we think about that, and how should we think about, how much is there an amount of money that should be put there? That's sort of a work in progress right now.
Right, and something that we have to bring, at least for the July 1 period, we have to bring closure before our next commission meeting about what goes in that blank. And I guess part of if you look at the calculations, part of what David worked through is to say, well, the maximum amount you could put in that blank, not the one that we would say you should put in the blank, but the maximum amount you could put in that blank based on the objectives that we laid out in the calculations are about 0.75%. Now, we're not suggesting that that's the amount that should be put in that blank, and Mike's saying, yeah, but it could be 1.25% if you just used a more a bigger differential statistic. So that was the dynamic of the conversation that was there. But we're not saying that it should be 0.75%. The right now we really we haven't seen we've made some calculations, but we really haven't seen calculations yet coming from the field on what their infrastructure needs are.
Yeah, I like the concept here, because when we do add the infrastructure, it stays. And when we are seeing with the regionalization and programs more in the community that need to have more staff managing some of those relationships, and so I like the idea of it.
Oh, and you know, the HSCRC and the consultants that have been employed with CRISP, we've done some preliminary estimates of staffing requirements on a regional basis, but you know that'll have to come out as part of the process, and we expect to help provide, as the regions would want it, some support to them to help them calculate staffing requirements. So just to really figure out what is it that we're going to need to bring better chronic care to scale in the state. How much is it going to take? What are we going to need? And yes, we will expect a payoff over some period of time, but we need an infrastructure to be built and to stay in place over time. So that's at least the concept that's being thought about from the care coming out of the care coordination work group. And I think we have the market shift, since I'm chatting. We'll shift to the market shift update and just give you the the current status of what we're working on. We've been working on fixing the outpatient data, some hospital resubmission, as well as the cancer care data to get the amount that's being pulled out corrected for the particularly for one APG that 3M marked as cancer drugs that really doesn't appear to be cancer drugs. So we're fixing that, and we also made one other change. It's not really a change, but we aggregated the data for the TPR hospitals at the county level, which is something that we said that we were going to do all along, and we've just got, we just did that in our calculations because the zip codes are very, very small in the TPR areas, and so we have a lot of small cell problems in the rural areas, we're running along in that analysis. So I don't know, Brett, are there any other things that you can think of that we've done that I didn't just say?
Yeah, I think the outpatient measure, the TPR aggregate data, I'll have a question for you in just a second on that. And then the other piece, I think, Shule was looking at the case mix grouper for the to potentially look at using the national grouper, if you will, which doesn't make adjustments for certain rehab and site cases, but that was still under discussion as well.
Right. So actually, she is looking at that.
Right.
Mm-hmm.
And I know she's not here to talk about this, but a question about aggregating the data by county for the TPR hospitals. Does that, because we look at all hospitals in sort of the virtual service area, where each hospital has a service area and a zip code service line, if we aggregate certain zip codes then for the TPR hospitals, do we look at all hospitals in the same aggregate for those counties?
Yes. So basically what she does is she replaces a zip code. If you think about the mechanics that are in the existing detail, instead of seeing a zip code for those areas, you'll see a county. So we still have all hospitals in the calculation, but they're in at the county level now instead of a zip code level. And there are a few counties beyond TPR counties that she picked up a couple rural counties that might not be in a TPR now. I think St. Mary's County is another rural county that it's involved in some of the TPR hospitals, but that one was aggregated. There are probably 3 other counties that that we might look at, but they're larger, but we still could look at to aggregate. I'm not sure yet if we have a thought about it, but we have Frederick County, which has a fairly distinct population. We have Harford County and Howard County. And again, they have a fair number of residents, but there's not as much. They're fairly fairly distinct geographic areas. Not completely, but and I'm not saying that we will move toward aggregating them, but they're at least on the thought list, just to try to avoid the situation as much as possible of small cells. Frederick County clearly has some rural areas, so so that's. But we have done all of the rest of the rural counties. Those are not rural counties, except Frederick does have a lot of rural area. Harford County has a lot of rural area also. Howard County, not so much.
Hey, Donna, this is Raymond. Thank you for considering the aggregation of the areas in the smaller rural areas. That was one of the comments you were going to receive from the group soon. Another thought that we had a discussion with last week is maybe there ought to be some threshold in the calculation similar to the thresholds that the staff rather has put in place around transfers. So you can think about that and see if that makes sense. And third comment would be to make sure that there isn't any duplication in the calculation of the market share with the transfer policy itself, because many of those patients may be leaving those rural areas and transferring to a to a teaching hospital, and that data may already be captured in the transfer policy.
Right. If we actually make a negative adjustment for any non-academic medical center, then we should subtract that out of any market share negative adjustment. Yes, we do need to take it into account for sure, Ray. You're exactly right, and that was the transfer. The transfer adjustment documentation indicates that that's the plan, is to take it into account.
Okay, thank you very much for that.
Thank you, Ray. Appreciate that.
Donna, this is Shirley.
Go ahead.
The other one is, we are thinking about more pilot studies for the prospective evaluation of some payer-driven or ACO-driven market shift calculations. So I just wanted to make sure everyone is aware of that part as well.
Right. So the calculation that we're working on right now is an annual adjustment type of thought process, but it's not the only time that a market shift adjustment might occur. We might have one during the year if there's some major event that takes place, some major combination, some major loss, some major payer shift, something big that happens could drive an adjustment that isn't part of the annual adjustment. And the most recent example of that would be St. Joseph had a very significant growth and a very negative financial position, and so we made a mid-year adjustment for St. Joseph.
Donna, just one comment. I think CareFirst would encourage the staff to continue the thought process about aggregating. I know you'd mentioned there may be some other counties that might be eligible for aggregating. I would also suggest looking at the sub-county level at some point when you're able to do so. Our concerns, I guess, stem around the idea of there being some degree of variability at the very detailed product line, zip code, cell level, and that variability could create uncertainty for hospitals that are doing a good job of reducing their utilization, that some of it could be taken away because of a potential random fluctuation up in those particular cells. You had also mentioned about trying to add to the potentially avoidable utilization categories. We would also encourage that as something that would be very useful, I think, moving forward. We know you're under the gun, with regard to trying to get something in place this year. So, as always, these methodologies do evolve over time. Thank you for considering those points.
Yeah, we have to get done for this year, but we do have some things that we'd like to do next year, and at a minimum, we would like to think about whether we could add sepsis to potentially avoidable utilization, since that's an area we want people to reduce, and we wouldn't necessarily want to have market share adjustments for increases in sepsis cases. And there is some linkage between the coding of sepsis and UTIs. So, that's kind of an area. The other thing that we would like to do with is to, similar to the way we brought the observation cases in with the inpatient cases, is to be able to bring in the angioplasties and the some of the spinal work in with the inpatient cases, so that we're not making a distinction between where you provide the service, inpatient or outpatient, but try to bring those areas back together in the data. And we think there is an efficient way to do it, but we've all been drinking from the fire hose this year with all of the changes. Other questions or comments? Are we we're in the 5 over mode here. Do we have any questions or comments from the audience? Are we? Oh, comments from the public? Okay, well, I guess we're in the under category. Hey, how are you?